Hello everyone, I'm Dr. Devraj Singh Parmar, Assistant Professor Cardiology UNMICRC. Today I'm going to discuss my topic tips and tricks in difficult BMV. So as you know, what are the causes of difficult BMV? There are certain anatomical features that makes the BMV very difficult, such as if the valve is severely thickened or calcified valve, high Wilkins score, severe subvalvular disease, small left atrium, or if there is a large left atrium with distorted anatomy or very tight mitral orifice. Associated conditions like dextrocardia, cord triatum, large interatrial septal aneurysm or previous BMV. And so there are certain even technical factors that makes it difficult, such as improper transeptal puncture site or inadequate fluoroscopy guidance. Now, what is the ideal site for the transeptal puncture? So BMV, so the ideal site for the puncture site is posto-inferior site in the interatrial septum. Basically, you align the catheter coaxially with the mitral valve. That reduces the risk of aortic rupture and the pericardial tamponade. Okay. So what are the other sites? Okay. Now when you see the interatrial septum, the ideal site for the PFO closure is a superior site. Okay. And the superior posterior even you can use for the mitra clip devices, and the posterior inferior used for the BMV. Now, what are the ideal sites for the Mullins sheath and dilator system? Now, in adult, as we know, we use 8 French sheath. Okay, the sheath length is 59 centimeter, dilator length is 67 centimeter, and it goes across the O32 wire. Okay, while in case of pediatric also we use a similar size of sheath, 8 French sheath or 6 French sheath we can use, and the length decreases. The sheath length is 44 centimeter, dilator length is 52 centimeter, and that also goes on the O025 wire. Okay. Now, what are the sizes of broken burrow needle? The broken burrow needle adult size is standard is like 18 gauge, and the tip size is 21 gauge, and the length is 71 centimeters. Okay. Now, as we know, now whenever we take a patient for the BMV, the most difficult part is the transeptal puncture. Now, in the transeptal puncture, we usually see in the multiple different projections like AP, RAO, and the lateral view. The first view, what we see under the fluoroscopy guidance is our AP view. In the AP view, as we can see here, it is very important. First thing is that whenever we are doing a BMV, first thing, keep the pictal catheter in the non-coronary cusp. Okay, and then you draw an imaginary line, okay, that ranges from the non-coronary cusp to the RA. Okay, and you draw another imaginary line at the center of this, and we usually take the transeptal puncture as around 2 to 3 centimeter just distal to the imaginary line that is drawn at the center of it. So LA is usually inferior, lateral, and posterior to the aortic root. So these are the all three different projections where we have to confirm, okay, that okay, our position for the broken burrow needle is at the perfect position. First is your AP view, where I already told okay, we generate one imaginary line from the non-coronary cusp to the RA. Then RAO view, and then a lateral view. In the lateral view, again you draw an imaginary line from a pigtail that is like from the non-coronary cusp to the like posterior border of the spine, and you generally puncture at the ideally in the middle 1/3. Okay, but basically whenever you're taking a transeptal puncture, you have to see in the multiple different projection, and then only we have to take the puncture. So what are the steps? Basically, first thing, whenever we are taking a patient with a BMV, okay, first from the left femoral side, take a venous and the arterial puncture. Arterial puncture should be the first. Take a 5 French pigtail catheter, place it in the non-coronary cusp. Then take a venous puncture. Then take a GR catheter. Take the PA pressures, and then keep the GR catheter in the pulmonary artery. Okay. Then take a right femoral venous puncture. Then in a venous puncture, you introduce the O32 fire, place in the superior vena cava, and over it you generally take the Mullins dilator, okay, and then keep it in the SVC, okay. Then over it, now take the broken burrow needle, okay. The broken burrow needle initially should be in the 12 o'clock position. It should be at least 2 to 3 centimeter just proximal to the Mullins dilator, okay, and then just keep it in the SVC. Then just slowly come down. Ideally, it should be like third bump. Okay, it's like from the SVC. First bump will be from the SVC to the RA junction. Second bump will be at the out, and the third you come to the limbus of the fossa ovalis. Okay, And then what is the position where you have to keep your broken bone needle is 4 to 6 o'clock position if the normal anatomy of the interdigital septum is maintained. Okay, so this is your ideal site where you keep, as it is perfectly shown, the ideal site for the broken bone needle should be from the 4 o'clock to 6 o'clock position in the normal anatomy of the interdigital septum. Okay, so as I already discussed you, what are the bumps in the transseptal puncture? Bumps are the sudden jump or the giveaway sensation that is feel while advancing the broken bone needle. So there are three bumps. First bump determines that you have entered the RA from the SVC. Second bump, it is a tactile sensation of your aortic pulsation aid in the localization. Third bump, as it slide over the limbus. Okay. Approximately 15 to 20% of the patient have a PFO, which allow unobstructed passage of the catheter assembly into the LA without any needle puncture. So now, if we can feel the multiple hard bumps, it determines the interdigital septum is thick, fibrous, elderly patient. So it is a difficult transseptal puncture. Now, how you can differentiate between safe versus dangerous bump? Okay, you should always determine the exact position of your transseptal puncture. If it is a high, it is usually at the side of SVC to RA. Ideally, your transseptal puncture should be in the middle. Okay, where you can feel it is like there will be the minimal resistance. It should be soft and springy. While if it is a little bit inferior, okay, it determines, okay, you can damage and it will be hard. So it can damage the LA free wall and the patient can present to us with a cardiac tamponade. So now what are the scenarios of difficult transseptal puncture? So in difficult transseptal, if it is a thickened or fibrotic interdigital septum, prior transseptal puncture is already done. If there is an aneurysmal interdigital septum, small left atrium, or there is a dilated RA, or the cardiac orientation is already changed, like there is unusual cardiac orientation like kyphoscoliosis, obesity, and a post-thoracic surgery, or operator-related factors such as inadequate needle shaping and orientations. Now, troubleshooting the difficult transseptal puncture. Okay, so if it is a thick or fibrotic or aneurysmal septum, now what are the things to do? So the first thing what we can use is like screwdriver maneuver. In a screwdriver maneuver, it's nothing. You just introduce a broken bone needle, because broken bone needle will easily penetrate the interlateral septum. Now, after penetrating it, our dilator is of 14 French, 14 French, so it will not easily penetrate the interlateral septum. So what we do is like, you generally move the dilator in the rotatory positions. So that is screwdriver maneuver. So it can easily penetrate the interlateral septum. Now, still if it doesn't do, then what we can use? Back end wire. Back end wire is also simple, that if your broken bone needle is only not able to penetrate the interdigital septum, what you do is like, you generally take the O14 or O18 guide wire, take the back end of the wire and then penetrate the interdigital septum, and then over it generally take the transseptal over it generally take the broken bone needle, and then generally take the dilator and do the BMV. The third technique is the latest technology that has come, okay, for the easy penetration of the interdigital septum, that is SafeSept. The SafeSept transseptal guide wire is a specialized nitinol guide wire that is designed for the transseptal puncture. So first you localize the fossa ovalis, a transseptal dilator tends the septum. Now SafeSept is usually a sharp supporter tip that is advanced to perforate the septum with very less force than a mechanical needle. Once you have entered, okay, once you have penetrated with this guide wire, then afterwards this guide wire takes a J-shaped position, so further it does not penetrate the LA free wall, okay, and then you generally take the dilator and sheath advance over the wire. Now, what are the key features of this safe system? As you can see, this diagram clearly demonstrates it is a less force required, atraumatic J-shaped tip, fluoroscopic visibility is good, and over the wire advancement. The sheath and the dilator can be advanced safely and smooth over the guide wire. And the fourth thing is electrocautery, that is poor man's radiofrequency. This is very easy. What you do is like, if the mechanical force fails, then you can use the thermal energy to melt the scar tissues. You connect our cautery pen to the metal hub of the broken bone needle, and the pulse, ensure the needle is standing at the septum. First you ensure, and then afterwards generally give a short burst of energy over your this broken over the broken burr, over the metal hub of the broken burr needle, and it will penetrate, and the needle will usually drop into the LA instantly with a short burst of energy. So this is usually what you done. As you can see in the picture, you can clearly demonstrate here we are generally give a short burst over the metal hub of this broken burr needle, so it can easily go through the LA cavity. Now last is your balloon predilation. It is also known as septal track technique. See what happens if you have crossed, okay, now the broken burr needle or the guide wire has crossed the interradial septum, but if you're not able to cross your dilator, so what to do? You take the small wires, balloons, predilate the interradial septum and then cross, okay, our large these dilators. So this softens the fibrotic ring, allows a large innoid dilator or the 18 French septal dilator to pass with less resistance. And the latest technology that we can also use, that is NRG radio frequency needle. Here this is a classic diagram that demonstrates how we can use. So this NRG transseptal needle is a radio frequency powered transseptal puncture tool. Here what we do is, instead of relying only on the mechanical force like broken burr needle, it uses a very short focused radio frequency energy that crosses the interradial septum safely and precisely. The only thing is, you have to first position and identify the exact side of the puncture, deliver the around radio frequency energy of around 10 watts at the tip. You can easily cross and then advance the dilator over it. So easier crossing in difficult anatomy. So radio frequency energy helps penetrate the thick or fibrotic septum, aneurysmal septum, previously scarred septum with less mechanical force than the standard device. It is also identified the shorter procedure time. Studies have significantly shown the shorter time to achieve left atrial essay with fewer puncture as compared to the mechanical needles. Lower radiation exposure, precise and control, because what happens in radio frequency energy, the tip of the device is blunt, atraumatic, that allows fine turning of the puncture location before radio frequency energy is delivered, and of course it has got the lower complication rates. Now transseptal puncture in a giant LA or giant RA. Now why is it difficult? Because what happens, the fossa ovalis, okay, whenever there will be stretching of the chambers, okay, the fossa ovalis becomes stretched and displaced. So the RA dilatation distorts the fluoroscopic landmark. So what you have to do is, like, what happens now if the RA dilatation distorts landmark, there will be increased risk of, if two posterior puncture, LA free wall, and two anterior, it will cause aortic damage. So excessive catheter instability, as the septum is more aneurysmal and floppy. Okay. So in that condition, when the chambers are dilated, anatomy is distorted, what are the tools we can use to exactly identify the puncture site? Is two latest technology, that is, one is intracardiac echography or transesophageal echo, that exactly identifies the position of your it's like transseptal puncture. And there are also certain sheets that helps to exactly penetrate the aneurysmal of your interradial septum. The latest technology that we use is steerable sheath. Steerable sheath, it is also known as deflectable sheath, that is developed by the Abbott. Using a steerable sheath that allows the operator to adjust the angle of approach, which is crucial when the septum is not in its usual orientation. In a dilated heart, the angle between IVC and fossa ovalis is severely distorted. So what happens, a steerable sheath allows us to actively aim the needle assembly, and if the septum is displaced posterior or superior, you can deflect the sheath to create a perpendicular approach, which provides better stability and support. So this is, we know that, okay, this is the latest steerable sheath, that is Agilis NXT steerable introducible dual wrist. It comes with a 13 French. So it has got a atraumatic tip, radio frequency marker, low profile design with lower transseptal crossing force. It has got braided shaft, bidirectional. It can rotate more than 180 degree, auto-clocking hemostasis. There are three stops for the air or blood aspiration, fluid infusion, and the blood samplings. Okay. Now this is the radio frequency needle. So what happens, because if you want to decrease, if the anatomy is distorted, if the aneurysmal floppy, You want to reduce the mechanical force because the complication increases. So we can use the radio frequency needles, which decreases the mechanical force. Okay, now how you shape it? So what happens if the RA, usually the normal transeptal needle, the standard curve is 50 degree. Okay, now if the RA chamber is usually dilated, you have to increase the angulation. Okay, and the larger curve you have to make it around 80 to 90, that is like 86 degree. Okay, so it becomes more reachable. Okay, now basically what happens in a if the LA in the left atrial chamber is normal, our broken burrow needle should be at 4 to 6 o'clock position. If the LA is usually dilated, okay, in this you have to increase the angulation of your broken burrow needle also, that you have to increase from the 6 to 8 o'clock position. So as you can see here, in a huge LA, the bulging position, you have to change the position from 7 to 8 o'clock position. Okay. There are also certain unusual cardiac orientations such as kyphoscoliosis, obesity, and the post-thoracic surgery. Transeptal puncture more complex than in the standard case in this other condition, because what happens, the primary issue here is the spine curvature physically rotates and displays the heart, making standard X-ray landmarks unreliable and potentially dangerous. So in this condition, we have to use intracardiac echo, TE, or transjugular access. Okay, so there is one case we are going to discuss. So this is a patient of a, as you can see here, the kyphoscoliosis. Okay, the patient, he was a 25-year who had a RSD with severe MS, and patient was being planned for the BMV. So as you can see, initially we tried with a transfemoral approach, but with the transfemoral approach, the transeptal puncture was almost difficult, and so that's why we abandoned, and then we went for the transjugular approach. So first what we did is, like, right IJ we cannulated percutaneously, then we put a Burman's catheter in the PA. Okay, then we took a pigtail catheter from the right radial sheath, we placed in the non-coronary cusp. Then PA angiography was done at the 45 RAO projection. Okay, then septal puncture was performed with a transeptal needle of pediatric. Okay, then what happened, the optimal site of the transjugular puncture is higher than that of the transfemoral, so it is superior to the fossa, it's about 2 centimeter. Once you're confirmed, okay, that this is the puncture site, then afterwards 5 French catheter is advanced over the needle into the left atrium and the needle is removed. So as you can see here, once you're penetrated, when the transeptal puncture was performed, then we have taken the O25 wire, and the guide wire was introduced in the LA through the 5 French catheter. Then we have taken a long sheath of 20 centimeter, that is 14 French sheath. Cook sheath was advanced in the LA over O32 wire. Then we took a Amplatz wire to enter into the LV, and then we performed the mitral valvuloplasty was done with John Neva balloon. So what are the indications where we should go for the transjugular approach of the BMV? The only one word answer is if the femoral access becomes difficult. Okay, so this is an alternative for the left atrial access when the standard femoral access is not feasible. Indicator is like if the patient has a IVC interruption or obstruction, congenital absence of IVC, IVC thrombosis, severe iliofemoral venous disease, chronic occlusion, or failed transfemoral transeptal attempt. So now the device that is developed for the transjugular approach is your LA cross system. The LA cross system for the transjugular approach. What happens, this LA cross system is a system that is developed by the St. Jude's. Okay, so it has first is like the superior most position stays in the SVC. Then we have got a mid port from where the catheter goes, and then we have a stabilizer sheath which gives support. Okay, and then from the mid port the catheter goes, and from there you generally puncture the interatrial septum, and then you can perform a BMV. Now intracardiac echo is utmost important in a patient for the difficult transeptal puncture, where the orientation of the transeptal is being changed, whether there is a chamber dilatation, and where we have to confirm the position of the transeptal. So precise site specific puncture, management of the complex anatomy, previous heart surgeries, because if it is fibrosed, already there will be chamber dilation, there will be complex anatomy, where we can use this intracardiac echo to reduce the radiation. So in the intracardiac echo, the first view as we is a home view. The operator positions the catheter in the mid RA, that allows the visualization of tricuspid valve, right ventricle, and RA appendage. Then you generally rotate the catheter in the clockwise direction, where we can see here the interatrial septum and the fossa is in the clear view. Now Visualizing of your tenting, when the transeptal needle and dilator are pressed against the fossa ovalis, the tissue boards in the left atrium, this is called tenting. And IC provides a crisp image of this tenting. Now, there are the last and the most difficult is your LV entry. There are so many cases where the LV entry becomes very difficult and you have to, it's like abandon even the BMV also, even after transeptal puncture. So, difficult LV entry is one of the most common results for procedure failure. It also increases the risk of complication. Now, there are factors which can make the LV entry difficult. If it is a critical mitral stenosis, giant LA, subvalvular disease, or abnormal septal puncture. So, there are different methods even for the LV entry. The first is vertical method. That is very easy. The stellate is generally placed under the balloon dilatation of catheter. Stellate is gently withdrawn at the onset of diastole. That allows the BDC to slide over into the LV, as you can see here. Now, if the vertical method fails, then what we do? Then you do it's like the direct method, that is stellate withdrawal and catheter advancement. What you do is like you take the basically here the BDC is withdrawn to align. First the BDC is aligned at the MA axis, it is kept near the mitral orifice. You see the bobbing movement, and after the bobbing movement during the diastole you generally withdraw the stellate and push the balloon dilatation BDC into the LV cavity. Okay, and the third approach, if both of these fails, okay, then we can use this horizontal method. Horizontal is used when the two fails. This is used when your puncture is very lower. Okay, stellate is here stellate is slightly withdrawn and the BDC is slightly pulled back to the horizontal position, make the entire assembly in the horizontal position, then keep the stellate fixed, okay, and the BDC is advanced over the stellate into the LVC. Once the BDC is in LV, stellate can be advanced gently to align the balloon segment to the M axis. Okay, and the last, that is reverse loop technique, or that is also known as hairpin method or alpha loop. This is the last if method where all other method fails, we can use this. Reverse loop maneuver is a specific rescue maneuver where the standard approaches fails. It is specifically designed for the patient with a hugely dilated LA or low septal puncture where the catheter tip does not align to the mitral valve. So what happens in a standard BMV, the operator uses J-shaped metal stellate inside the balloon to point the tip towards the mitral valve. However, if the atrium is very massive, the catheter tip does not align. So what we do is like we generally make this BDC. First, the BDC is inserted here. The BDC is inserted deep into the LA near the mitral valve to make the large catheter loop. Then what we do is like stellate is withdrawn to a 0.2 to 3 cm just proximal to the balloon segment, and then the stellate is rotated clockwise to bring the balloon tip towards the posterior and the inferior wall of the LA, as you can see. So it makes it a full loop, and this will cause the BDC to form a loop inside LA after bouncing off the posterior LA wall. The BDC now points towards anterior towards the mitral orifice. Now then, with the stellate held firmly, once the BDC is advanced, allow it to move forward to the mitral orifice and cross the LV. So once the BDC enters the LA, inflate the distal valve. So once inflate the distal valve, see the position that okay, it has not entered into subvalvular apparatus. So it should be very freely mobile. Once you feel that okay, now it is freely mobile, means it is in the LV cavity. Then you generally keep that inflated balloon back. Okay, then inflate a balloon back. You feel the resistance so that you are in the mitral valve apparatus, and then go for the inflation. Now, the other technique where there is a critical mitral stenosis, you are not able to penetrate even the mitral valve, that we can use this over the wire technique. Here, when the standard techniques are failed, it is using as extreme stenosis, distorted anatomy, or giant left atrium. Okay, equipment method is like here you take a JR catheter. Okay, guide wire that is used is like O30 to O35, the J-tip hydrophilic wire. What you do is like it's exchange wire with the A-tip pre-shape exchange wire. Okay, and then over that you generally do this BMV. Okay, so it is very important. First is like the inner balloon is withdrawn and the diagnostic catheter is advanced to the Mullins seat. You find the orifice under the fluoroscopy in the RO projection. Operator rotates the diagnostic catheter and the tip should be facing the mitral valve. Now, unlike the balloon, the catheter is thin. As a catheter it is easily mobile and it can you are easily able to manipulate the catheter. So the operator gently probes with a hydrophilic wire until it drops the stenotic mitral valve and then it enters in the LV. So establish the rail. Once the wire is in the LV, diagnostic catheter is advanced. Over that, you take the stiff exchange wire, and the tip of this exchange wire is coiled in the pigtail shape, so that so it does not damage the LV wall. And then over it, you take the Inouye balloon, and you generally inflate the mitral valve orifice. There is last technique, that is like veno arterial loop. Veno arterial loop is usually considered the ultimate troubleshooting technique in a BMV. What happens? It is used only when all other maneuver fails, including the alpha loop standard, everything. So it is mainly used in scenarios like giant left atrium, extreme subvalvular disease, and severe scoliosis or kyphosis. Okay. Here what you do is like, first is like, yeah, it is very easy. You take a JR catheter, same. Okay, you take a JR catheter from the LA, take the hydrophilic wire, introduce in the LV. You take a Teramo wire from the LA, LV, and the outer. Okay, then you take a femoral artery puncture, snare it, and then complete the loop. Once the wire is captured, it is pulled out to the arterial sheath. Okay, by holding, you hold the both end of the wire. You create a rigid, stable, tight trap across the mitral valve, and then you take the BDC catheter from the venous side, inflate the mitral valve in this, and then come out. Even the most calcified and slippery valve cannot deflect the balloon. Now, there are certain other scenarios. If there is a dilated LA, okay, large LA, the septal puncture is chosen more caudally than usual. Distal curve of the needle more sharper, and the LV entry often has a wide curve. In case of large RA, what we do is like, you increase the gentle curve of the transeptal puncture needle. Ideal, your standard curve should be 50 degree, but if there is a dilatation of chamber of the RA, then you increase your the transeptal puncture needle curvature to 86 degree. Okay, then we can even do the left femoral vein approach. Due to altered angulation of IVC, transeptal needle engage the fossa ovalis in the more parallel and the perpendicular position. This can lead to dissection of the IES. So turning the body of the patient with the RA and increases the distal curvature of needle to approximately 40 degree helps to improve the angle of engagement of the transeptal needle to the interatrial septum, and that facilitates your puncture. Okay. Now, there is also a condition, dextrocardia. Okay. So what we do is like, here you take a left femoral vein approach, fluoroscopic inversion is done, you delineation of the interatrial septum by levo phase. Okay, in the pulmonary angiography, septal contrast staining are helpful. In interatrial septum puncture is done with the transeptal needle as 7 to 9 o'clock position, and then the LV entry can be done using the routine technique by reverse loop tactic. Okay. There is also a breakage of the LA coil wire. LA wire can break at the junction of soft coil part and the hard part. Care should be taken to avoid injury. Thank you.